Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. Hello and welcome to another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. Today I'm joined by Dr. Greg Dumanian, and we sure appreciate you coming on and joining us today.
Oh, thanks for letting me participate. This is great.
Absolutely. Well, we start, before we get started, I was saying before we came on, back at American Hernia Society this year, I had the opportunity to meet you, and we had talked at that point just a little bit about the whole idea, and I was super interested in kind of the way that you got where you are in your career and what you're doing now. And so you were one of the baseline inspirations to have these types of discussions. So it really is a full circle moment for me, for you to come on and have a talk with us.
Sounds great. Again, my pleasure.
So why don't you start by telling us a little bit about who you are, where you come from, and how you got where you are?
Well, I'm the son of a very well-known cardiac surgeon. He came from originally Aleppo, Syria, and then Beirut, and then the United States. He came in the late 50s and had an extremely successful cardiovascular surgery practice in Northwest Indiana. At that point, Northwest Indiana was the richest county in the entire country because of all the steel mills and factories and refineries. And I looked at a lot of different things of what I wanted to do, but, I kept coming back to maybe I should just be a doctor. And then those days of doing surgery as a medical student, it's like, I really need to be a surgeon, just like my father and my great uncle and his father before that. So we come from a long line of surgeons. I went to the University of Chicago, where I was interviewing at a whole bunch of residencies, and I ended up at the Mass General Hospital. So hardcore general surgery, 120 to 140 hours a week. I was telling one of my residents this morning, I got married, and then I was in-house the next 10 months. So super, super demanding. And while I was there, I decided that I really wanted to be a plastic surgeon. They did a lot of hand surgery on general surgery, and I thought, oh gosh, I don't want to be a cardiac surgeon like my dad, but hand surgery really is what I want to be, what I want to do. So I went to the University of Pittsburgh for plastic surgery. That was a year of research and 2 years of plastic surgery training, and then I did a hand fellowship after that. But while I was at Pitt, the story of why Pittsburgh was associated with the components release is a really funny story, which you may not know. The anterior component release was done by Ramirez. But Ramirez was a general surgery, a nice guy, Oscar Ramirez, and he did it at the Union Memorial Hospital when he was in Baltimore. He did the dissections at Union Memorial, which is where I did my hand fellowship, by the way. That's where I learned this whole story. And then Oscar finished general surgery at Union Memorial, came to Pitt. Mm-hmm. He was there about 1989, where he started to do his component releases at the University of Pittsburgh. Okay, so, or maybe it was 92 that he wrote it up. So then I was there 92 to 95. So the first big cases I was doing were anterior component releases. And that was just a throwaway, a throwaway, you'd be doing real plastic surgery things. And then they're like, hey, close that abdomen for the transplant surgeons. Okay, so we would go down and we would just do it. And this very vivid patient, I walked into this room, and it was a 350-pound guy, and the plastic surgeon had lifted up all the skin flaps. And I said, hey, can I help? He goes, yeah, Dumanian, close this guy. So I just walked in and just started closing his fascia. And again, I had done general surgery, so I'm fine. And then that guy had the most horrific wound complications, being 350 pounds and having these undermined skin flaps. So I took care of that guy for months. So that all was stuck in my head. And then I'm getting to how I'm a hernia surgeon. And then one day I was in conference at the University of Pittsburgh talking about this guy who had had an aortic tube graft and then had an anterior component release. We called it the separation of parts then. So that was the name, the separation of parts. And he had had his tube graft and had a hernia, and the resident lifted up the skin to release the external oblique muscle and fascia to get his abdominal wall together. And you can imagine if you lose your umbilical perforators and then you lose your intercostal blood supply from the tube graft, this guy lost all the skin of his abdominal wall. Mm. And I was an M&M, and the guy next to me, Ken Shestak, said, why couldn't we just go around those perforators and do the same thing? Mm-hmm. So I was on one side of Ken Shestak, and the plastic surgeon on the other side, the resident, went to the University of Texas, I think at Austin. And he was the one to do the first component release with perforator preservation. That was the first description. Okay. Anyway, so that will segue from that. I went and did my hand fellowship. Came to the university. I came to Northwestern as my first job to be the local hand surgeon on the full-time faculty. But at that point, Northwestern had a very bad town gown problem. Half of the surgeons were private, half were full-time academic. Mm-hmm. And the orthopedic surgeons shunned me from being a plastic surgeon, from being a hand surgeon, excuse me. Mm-hmm. And I needed something to do. And my first big case was a fascial dehiscence with an open abdomen and intercutaneous fistula. And no one knew what to do with it. I said, I used to do these all the time in Pittsburgh. I would just skin graft the open wound. We'd convert the wound into a fistula, put an ostomy bag, let the patient get better, and then we would do a component release. And the general surgeon was like, well, if you know how to do that, you take care of this patient. So my first big case at Northwestern was a hernia abdominal wall reconstruction, which I had written up at Pitt. And then I got a couple infected meshes, midline meshes. And so then I just excised the mesh, plastic surgery principles, did an anterior component release, and they all did fine. Mm-hmm. And so this idea that I'm a hand surgeon, but not really having much hand to do. And then the real need at Northwestern was for a hernia surgeon, abdominal wall surgery. And I'm like, well, I can do that. I'm a general surgeon and general surgery trained, and I know how to do this anterior component release. And then remembering Ken Shestak and that M&M at Pitt, I started going around the periumbilical perforators to do these releases. And I was having, it was like the complication rate of just a laparotomy. Mm-hmm. So I had a gimmick that worked that made these cases to be done in 2.5 hours with low complication rates. And there was no one else in Chicagoland doing it. This is 2002 that I wrote up the the perforator preserving component release, or separation of parts, which why people, when they look it up, don't find that article.
I see.
It wasn't called an anterior component release. We called it the perforator preserving separation of parts.
Oh, okay.
Based on the old name. And by 2009, I had done hundreds of these anterior components, and we wrote that up, and we had an article in Annals of Surgery on component release, Archives of Surgery, and for a long time in Chicagoland, I was one of the dominant hernia surgeons, only by accident. So that is the story. How did a plastic surgeon who's really wanting to do hand surgery become a hernia surgeon? But then when I think about it, an abdominal wall surgery is just putting two tendons together, which is the whole thing of hand surgery. In hand surgery, when you cut your flexor tendons, the collagen is very lined up, very linearly. And so plastic surgeons, hand surgeons have all this intricate stitching of flexor tendons so that you don't get suture pull-through. Suture pull-through is that concept when a tendon repair falls apart. It's not because the suture breaks. It's because the tendon has cut through the tissue.
I see, yes.
So to a hand surgeon, suture pull-through is one of the biggest obstacles of doing successful surgery. And as I'm doing hernia surgery, I'm recognizing it's the same problem.
Yeah.
The stitches, which you put in the fascia, cut through the tissues, and you get failure.
Mm-hmm.
And that's my story or entry into the hernia world.
Yeah, that's fascinating. So so it's kind of interesting. A lot of people that come on the podcast are about the posterior separation, and obviously it's funny because a lot of the from the things that I was taught coming through, a lot of it was a concern about flap preservation in the anterior component separation, and obviously that's one of the things that you identified as a problem very early, and then solved it. It sounds like just the way that you have thought about the procedure and the limitations of the procedure, and then subsequently the failures of the procedure have come from a very different thought process than majority of hernia surgeons, and a lot of that comes from your experience as a plastic surgeon. I think that's pretty fascinating, considering that we come from things at different angles, and it really, when you get those ideas that merge, it can be a brand new way of thinking of something that other people may not have thought of just because of experience.
Well, to me, as a plastic surgeon, the world of general surgery has moved away from anything that has anything to do with skin. Mm-hmm. You don't, and not that you can't cut skin, but you're just not familiar or trained to deal with the complications of skin elevation, which is seromas and abscesses, and so from the plastics world, it frees you to do lots of different things if you can see the abdominal wall, work on the abdominal wall, and not worry about what's going to happen to the skin for the post-op healing. So it's just part of our specialty. And so we gravitate to skin. We think of, or plastic surgeons or myself think of hernia world as two different surgeries. It's the abdominal wall surgery, and then there's the skin tailoring on top.
Yes.
And they're related, but they're independent questions.
Yes.
And so then the most versatile surgeon for hernias should be able to manipulate both independently. Mm-hmm. Now, the plastics world doesn't do MIS surgery. And that is one of the limitations of our training paradigm that I don't do. At Mass General, I did the first cholecystectomy laparoscopic procedure, which was I mobilized the left colon and brought it up as a diverting end colostomy. That was the first non-chole procedure done at Mass General. But after like 10 laparoscopic procedures, I left the general and haven't done one since. So, I think that bringing the two worlds together, the skin players and the non-skin players, or the MIS people and the skin experts, that is what's going to provide the best overall hernia care. And Mike Rosen, who's now at Northwestern, and I have had a really fun year since he's arrived at Northwestern, because it's just two different thought processes coming together.
Absolutely.
Yeah.
Well, it's interesting because we take care of these large hernias that the redundancy of the soft tissue over the top of the fascia and the distortion of the soft tissue due to the hernia sac is always something that it's not ideal, right? And so many times those end up being staged procedures where we take care of the hernia itself, and then they come back for an abdominoplasty later with our plastics team or something like that. But really the limitation of that is the fact that, the abdominoplasty many times can't get the coverage. And so the limitation of finances really contributes to getting the hernia repaired, but maybe the aesthetics aren't what they really wanted. And that is where I think that we have a lot of room to grow in, as far as being able to take care of the whole patient. Some of that's, surgeon limitations from experience, and some of that's just systematic limitations from the finances of it all. Because ultimately, I would love to do combined cases with my plastics colleagues all the time, because I think that the cases I've done together are they've turned out just beautifully. But yeah, it's a really interesting thing. You were talking about the tendons being.
I was gonna go back one thing. The York
Sure.
Hernia Center at UK, they're friends of mine. Their patient outcomes, the highest patient-reported outcome improvement after hernia repair is the aesthetics.
Yes.
The patients care more about the aesthetics than they care about hernia recurrence or immediate post-op wounds. Mm-hmm. So if you're really going to provide the ultimate procedure, that has to or should be part of the equation.
Yes. Yeah, I agree. It's and the the performance of that aspect of the procedure has tips and tricks and techniques that are not obvious, and they may seem obvious, or you just kind of do this and this and take a little extra tissue, but the outcome very much depends on a lot of factors that plastic surgeons obviously take into account on a daily basis, and general surgeons are looking more at the structure and function of the deeper layers.
I agree, because your toolbox is let's go deep and leave the skin alone. Mm-hmm. And until the general surgery world can play with wound complications, seromas, necrotic skin, managing those as an outpatient in a very expeditious manner, well, then the worlds will stay apart. And and that's not the best thing. But then again, two individuals coming together with different skill sets, that works too. So totally reasonable.
Yeah, it is definitely part of when we've kind of moved into more the larger hernias. Again, I've said it before on the podcast, really like the point that you just made. When people come in to talk to you, I have found that you can go and do a really good hernia surgery on somebody and not accomplish the goal that they came to you for, because their goal wasn't even necessarily the hernia. And that, and whenever that finally kind of clicked with me, then I got very specific about asking for their goals. And it is always a tough situation to be in, and a lot of extra counseling that I go through whenever I do find a patient that their goals are, yes, hernia repair, but a lot of it is aesthetics. And so I get those over to our plastics folks. They come back and they're like, listen, I need the hernia fixed, no doubt. We all agree on that. But I really can't afford to move forward with the other aspect. They don't have, the paniculitis that can be documented as to justify that aspect. And I don't know if there's room for improvement of our documentation or the way that we can get these things approved to get them some help, or maybe we just need to explore more of a systematic package-based approach for the way that these can be, think outside the box, so to speak. But it definitely does require more when we realize that it's not just the hernia that they're looking for.
What I do in my office is I'd say a third of the patients will pay extra money to do what we call skin tailoring. Mm-hmm. We're not really focused. We're not calling it abdominoplasty, but that's what it is. Mm-hmm. But I want to free your brain to. It's not always a low transverse incision. Right. So a lot of I do vertical abdominoplasties. I've written on it, where I will do the way I put in a retrorectus mesh. I will, go into the abdomen, close the posterior sheath, put in what I call a 7.5 centimeter wide and narrow, well-fixed mesh. Very different than the way general surgery tends to put them in. I'll use a mesh suture on top. And then at the beginning of the case, I'll do transverse lines equally spaced with staples so that I can help to line up the skin at the end of the case. And then I will do most of my excision in a vertical plane. Mm-hmm. And then I will sit the patient up about 30 degrees and in the suprapubic area or the underwear line for a guy. And then we'll do essentially a dog ear transversely. And I can do a narrow, well-fixed mesh with a full, essentially abdominoplasty in about 3 hours. Mm-hmm. And then their hospitalization, at least the post-operative care, is covered by the hernia repair. So they just have the 1 hour of OR time and the surgeon's fee to do the extra skin. Otherwise, and to make an umbilicus. So at the same time that you excise the skin, you leave little 2 by 2 centimeter, what I call pumpkin teeth flaps. And you take those skin flaps and tack them down to the abdominal wall, and you recreate an umbilicus. So then the scar is broken up by the indentation of the umbilical area. And for plastic surgery, it's called the aesthetic subunit. For the nose, there are particular types of places you're supposed to put an incision. Well, for the abdomen, it's the vertical. You already have that indented line. Mm-hmm. And so then if you have a vertical line with an umbilicus, it becomes very acceptable. And so in the worst cases of rectus diastasis, I will convince the patient to have better balance between the upper and lower abdomens to actually do a vertical abdominoplasty.
Yes.
And overall, the acceptance rate is very high.
That's interesting. Yeah. So you just for this is, I have increasing numbers of these types of patients. Exactly what you're talking about. My wife's an OBGYN, and so I get. And then here in Orlando, we have one of the largest in our system. We have one of the largest OB hospitals in the country. I think it's like 14,000 deliveries a year. And so whenever we see an increasing number of women that come in for just massive core weakness with the associated, constipation, the back issues that are associated with that, and the pelvic floor dysfunction that all kind of interplays. And they come in for these massive diastases. I have a couple in my practice right now. They're between 12 and 15 centimeters. And so these are, obviously big things to deal with. When you are talking about tailoring them with a vertical abdominoplasty, you are removing the umbilicus and creating a neo-umbilicus. Is that correct?
Every time.
Okay. Yeah, because I will say that has been my biggest struggle, because again, if I do it open for a size that big and you pull it together, it's hard to get things to line up because if you're trying to maintain the umbilicus, there's like this pull of the anterior. It's hard.
So I do transverse lines at the beginning. I do a vertical line between the xiphoid and the symphysis. Mm-hmm. And then I do transverse lines. And, it doesn't matter where you put your staple, 10, 12 centimeters wide on the skin. Mm-hmm. Then I will go in. For the worst cases, I'll do what I call a mesh abdominoplasty. And yes. I'm doing transfascial sutures I usually use a 11 centimeter wide mesh for them, because a normal female rectus muscle should be prepartum, someone who hasn't had children, is 6 centimeters wide.
Yes.
So if you do an 11 centimeter wide mesh, you take bites, usually like 10, 11 centimeters from the medial borders of the rectus. You're pulling the semilunar lines together, and actually it bunches up the rectus muscle, which has been all stretched out. Mm. And so then, again, the marks of female beauty, we did a internet-based study, is the vertical linea alba and the semilunar lines. That's the first 3 things that men and women look at for female beauty. And so one of the problems I have with tar releases is that it destroys the semilunar lines, right? I mean, the posterior components. So you destroy the semilunar lines, the abdomen looks kind of round, and you're moving against female aesthetics. It was a female study, not men. But having that semilunar, that lateral border that you can see through the skin actually is kind of important. So when I'm doing abdominoplasties, when I'm doing vertical abdominoplasties, I try and save that attachment of the skin to the lateral border of the semilunar line to help recreate that. And I just want all my fixation right in the midline, as opposed to posterior component release, which just by friction is using a huge mesh. So to me, posterior release is working against the things that I want to achieve in an abdomen. Mm. Yeah. So that's why I only do posterior releases on rare occasions for deep flat bulges or breast reconstruction related harvest site bulges, where you have a low transverse incision, you don't have good rectus muscles, the semilunar line connections have already been elevated. So I do a tar release on them, again, because they, that lateral aspect, you don't have the rectus muscles to pull together in the midline in those cases.
Sure. Yeah, one of these days you're going to be in the operating room and look over your shoulder, and I'm just going to be like peeking over to see what you're doing, because I need to know. I have quite a few patients I think would very much benefit from that knowledge. So, yeah, no, I think that
no one has ever watched me do surgery other than my residents. I have never had a visitor ever. 30 years. Well, come on by.
I'm there. I love Chicago. Yeah. I just got done watching the Bears, so I'm all about going up there and eating some fine dining.
I saw the Packers game, and it was just the best game ever in my life. Unfortunately, I've now seen the best football game I could ever see, which was that onside kick during regular season. I mean, you can't get any better than that.
Yeah, my brother is a HEMONC doc up in Chicago, and so he lives in one of the condos there overlooking Navy Pier, and so he was. But you'd be sad to find out that he's actually a Packers fan, and so he was listening to the celebration, and it was a bittersweet moment for him. His team lost, but he also my brother's wanted to live in Chicago. But we grew up in the Oklahoma Panhandle, and we had like zero connections to Chicago whatsoever. Nobody lived there. Nobody had ever been there. Like, we're just farm boys in Oklahoma. And he, for some reason, from like the age of 5, he was just obsessed with Chicago, and decided he wanted to be there, and ended up going to up there to Loyola, and then went through his fellowship, and now he works up there. And so I love Chicago. So like I said, I'm down. You just let me know. I'll come observe.
That's fine.
Well, one of the things you were talking about was the mesh pull through, and the fact that the linea alba is a tendon. Yes, it obviously is a tendon. I don't think I ever really thought of it that way. Just from a logic standpoint, is that so? Then the suture pull through, was that really one of the first things that made you start thinking about mesh as an alternative to standard suture?
So, yes, I had seen, so when I wrote up 200 anterior component releases, lessons learned, I had a 23% recurrence rate at almost 2 years. And if you look up if you do a standard laparotomy, closed with sutures, the hernia rate at 3 years is about 23%. Mm-hmm. So there's some factor of, in a certain number of people, the scar that's created from a suture is not strong enough. Not a kid, yeah, it is going to be strong enough. But, a scar is only 70% as strong as the tissue is replacing. So in a certain number of people, if you're just using a suture, it is not enough. Mm-hmm. Even small bites, the famous small bites, the E20 trial at 5 years you could see the recurrence rate every year just getting higher, mm-hmm. because an absorbable suture, when it goes away, leaves scar. Scar in certain people is not strong enough long term. The scar remodels and fails over time from the pressures applied. The bigger you are, the more the pressure. Mm-hmm. And early on, right after you place that suture, you have suture pull through. And so then the linea alba is stretching. And Pollack, back in 1987 with metal clips, showed that if at 1 month, if you put, right after when you do a laparotomy, you put clips on either side of the abdominal wall. If you take a plain film at 1 month, if there's 15 millimeters between those clips, there's a 90% chance you're going to develop an incisional hernia. So suture pull through happens immediately. And then over time, that scar where the pull through happened fails 23% of the time, even when you do component releases to reduce the tension. So reducing the tension is important, but it doesn't solve the problem. And then what about a permanent suture? Well, we all know that when you see a permanent suture, you can just strip it out. So a permanent suture has no permanent hold.
Okay.
So absorbable sutures and permanent sutures have the same laparotomy failure rate, but for different reasons. Okay. So then I've been thinking, and then, you have those cuts on your fingers from your posting hand, right? You got
Yes.
those. When I was a Mass General resident, Ron Malt was the one of the senior surgeons. And he used to do something called the Superman closure. At that point, there was something called a number 5 at nylon, a number 5 nylon. And we would triple glove our hands to tie these knots. And we would get cuts on our posting finger. And at the evening meal at 9 o'clock, we would compare the cuts on our fingers. Oh, that's a good one. Oh, did you triple glove? Yeah, triple gloved. So I knew that a suture could cut intact tissues even through an intact glove.
Yes.
So I'm seeing my failures. I'm thinking of the meals when we would compare the cuts on our fingers. And then one day, it was 2011, I was driving my daughter to horseback riding, and I had a flash. How about a suture that had mesh-like characteristics to distribute the forces so you wouldn't cut your finger?
Okay.
I mean, I'm playing with meshes all day, right? I'm a hernia surgeon, but I'm a hand surgeon and thinking about the cuts on my finger. And literally, that's how it happened. And I could tell you what block I was at when I got the idea.
Mm-hmm.
And that was the genesis of the mesh suture.
And you started by cutting strips and kind of cutting back and forth. And is that how it started, taking flat mesh and cutting it?
Well, what I did was, so we had the idea, okay, and then we, it's the whole university owns the idea because I'm an academic.
Mm-hmm.
So then we filed our provisional patent, and then we went to the lab, and in the lab, from the excess mesh that I wasn't using in humans, we would cut little strips, and we started doing hernia repairs in rats. Okay, so what we did was we created a rat incisional hernia by doing a laparotomy and then closing it with some plain catgut. A month later, you would open it up, it would be an established hernia. And then we were closing these little rat hernias either with a 5-O-proline or a tiny little mesh strip.
Mm-hmm.
Okay, simulating what a mesh suture would be like. And wouldn't you know it, 100% of the mesh strips stayed intact, did not pull through, but 65% of the prolines pulled through.
Mm.
So that's pretty good.
Right.
So we knew we had something in that direction. And then back in the clinical world, when I would have extra mesh after a retrorectus, I started taking little strips of mesh and I'd put a snap right through the abdominal wall and I'd grab the strip of mesh and I'd pull it through. So that was how we did it. And then we would tie a couple knots, and then I went to the lab and figured out that a 20 millimeter wide piece of soft polypropylene mesh had the strength of a number 1 proline.
Okay.
So I tested a centimeter, 12 millimeters, 15 millimeters, 18 millimeters. At 2 centimeters, it was stronger than a number 1 proline. And I also tested I only needed 3 throws. So I started using that on the top of a retrorectus. And then around 2015, a lady came in with her left rectus muscle completely in 2 pieces in an open abdomen. And I'm like, gosh, I've never seen a divided rectus muscle from trauma acutely. And I'm like, why don't you give me the mesh? And then I cut the strips of mesh and I closed her left rectus muscle. And that helped. And I closed her midline with just mesh strips. And, because it was a dire situation, and that worked. And then there was this one lady, very important in my career. She had a 14 centimeter wide contaminated hernia. She was getting a Hartman takedown. She had a skin grafted abdomen. I'm going to do a component release. And I'm still a little bit embarrassed about using these mesh strips. So I did mesh strip and then 2 prolines. Mesh strip and then 2 prolines, all the way down.
Mm-hmm.
At 9 months, she got a hernia, but it was really an unbelievable hernia where she was intact, and then she had a little hernia. And she was intact, and she had a little hernia. And she was intact, and she had a little hernia. And everywhere she was intact, she had a mesh strip. And at that point, I said, these mesh strips really work. And so I've probably done 1,000 mesh strip cases. And it's being done, it was really being done around the world. I mean, I was in India at the big hernia meeting there, and Jorge Diaz, who I didn't know, was sitting next to me, and he goes, "You're the mesh strip guy." I mean, and that really made me think, gosh, I'm in India and some guy from Colombia recognizes who I am. That's really pretty cool.
Yeah.
And so then I recognized that the idea was reverberating within the hernia community, something bigger than a standard suture to resist acute suture pull-through, and with a porosity for tissue incorporation to become stronger over time. And that and I was getting away even with dirty wounds at Northwestern with a very low SSI rate. And so I've come up with this really strong idea that multiple filaments, even though it has a higher amount of surface area, gets infected less than a big, large suture, which has a big diameter filament, but even though the total amount of surface area for material is less. So the body can tolerate small filaments better than big filaments. And there is a little bit of rat data from Germany that the tissue response to a small filament is somehow more histologically normal than the tissue response to a big filament. And that also goes along with my clinical experience for chronic draining sinuses from sutures, that I have never seen a chronic draining sinus from a polypropylene suture, which is 3.0 or smaller. I've seen one 2.0 proline cause a chronic draining sinus. Most of them are 0 or 1.
I see. Yeah.
And again, I think it has to do with filament size. So even though mesh strips have a lot of filament, it's on the order of 100 microns or 120 microns, where a polypropylene suture is 400 microns. And that's the sweet spot, getting it to be 200 or less as opposed to 400 or more.
So is there a case you won't use it in? So
that was mesh strips. If we're segueing to mesh suture,
yes,
mesh suture has a contraindication for CDC4 wounds. Okay, so if you really have a dirty wound, yes, it's up to the surgeon, risk benefit, and there are a few people where if you can convert the CDC4 to a CDC3 contaminated wound because of bioburden reduction and debridement, well, then you can use a mesh suture. But if it's truly dirty, surgical principles, you should leave it open for colony counts to fall.
Okay. Now, you obviously the tensile strength, I've used it multiple times, and use it more frequently now than I did before. So the tensile strength when you're pulling it through obviously is much stronger whenever, in my experience. Is there a tension on the wound that you are more tolerant of utilizing mesh strips or mesh suture now, that you're more tolerant of than you would have been in the past while doing more of a tension release, expanding the procedure to relieve more tension on the midline closure? Or do you still adhere to the exact same tension release principles for the tension-free closure if possible?
That's a great question. I mean, so I am in my hernia practice, I always just think about suture pull-through. That is the main thing I'm thinking about. And so when I see someone in the pre-op state, I'm not even talking about prehabilitation for what they eat. I'm only talking about prehabilitation for their abdominal wall compliance. So lose weight, and then I have patients for big hernias. I have them lie on their bed and have their loved one push on the hernia to physically stretch out their abdominal wall.
Oh, I see.
That's my prehabilitation. And they can breathe against it, so their lungs get ready for that. Okay, so 5 minutes, put on an end timer, have fun, open your hands, and I make them take a video. So I do it when they're in the office. Take a video, and then I will do the exercise. I'm pushing down on the hernia. Now breathe for 5 minutes. Okay, that's my prehabilitation.
That's interesting.
And then, and if I think they're going to need it. I'll use some pre-op Botox, 150 units on each side, 3 weeks before. And then in the operating room, I do something called the 2-finger test. And if I can take my finger, if I can take the rectus muscle, which has been dissected, and I can bring it together with my 2 fingers on each side, they don't need a component release.
Okay, so one on each side and pushing together in the midline, just the two fingers touching.
This doesn't need a component. I'd say about a quarter of my patients get an anterior component release with perforator preservation to decrease the tension on the suture for closure. Okay.
Yeah.
And so then there's certain situations. Let's say it's a burst or open abdomen, and I'm closing it. And there's some benefits of just closing the thing. You know that there's a higher chance of getting a hernia, but you have such a benefit from closing that you're going to tolerate a little more tension. Then I will do that without the anterior component release, saving that for another day when they're optimized.
Right.
And then a really nice trick is to put the mesh suture in like a shoestring, and then just slowly just tighten it with your finger, and then you can close basically almost anything. Okay, so yes, if I don't see it tear, and I would just good surgical technique and not really yanking up at once, causing tearing, then yes, I can close things under more tension that were but previously with a standard suture would have torn, but I can get it closed with the mesh suture successfully. So I'm doing less anterior component releases. Botox is just for an elective case. But there have been patients with burst or open abdomens where I see them on day 0, like general surgery will call me, and I'll just get the Botox, and under direct vision on day 0, I'll inject them.
Oh, I see.
With the plan, I'm closing them at day 6 or 7. And that's, in my hands, has worked really pretty well.
Interesting. Okay. And do you ever use Botox, not only in times when you think there's going to be the need that the component separation is probably going to be necessary? Do you use Botox to avoid component separations?
Yeah, and like some firefighters or people like that, I really don't want to do an anterior component release, but I've done 1,000 anterior component releases. No one really has a problem from it because you're not removing the muscle, you're just changing its insertion. So you're weakening it a little, but it's still there. You can twist. It's still got all of its innervation. So it is not a big deal to do an anterior component. But there's some people where philosophically, I really shouldn't do it. So there was a 10-year-old who had a skin-grafted abdomen. It's in the literature, about 10 centimeters wide. She was 10 years old, and she was going to need a kidney transplant at some point. And I didn't want to release her external oblique fascia in case in her fossa she needed something later on.
Sure.
So even though she was 10, she got Botox. And then I could just close her in the midline. So there are a few isolated situations. And unfortunately, again, it's not covered. But what I do in my practice, I sell them the Botox at cost.
Okay.
So they come in, they buy the Botox, but interventional radiology will put it in. There is a CPT code for that.
Mm-hmm.
And when I tell people they'll have less postoperative pain and it'll be easier on them and easier on me, I'd say 90% of people can come up with the funds. And for that 10%, I'll hit the rep up to say, hey, can you get some Botox? And typically they'll.
Yeah. Our experience is that the postoperative pain improvement is significant. And then, you see them back at the 2, maybe the 4, the 6 week mark, and they're still a little floppy. We are doing mostly posterior releases. Right. So it's going to be a little different. Right. But over time that starts to, you can see the Botox effect wear off, and they do kind of tighten up, and that's it's nice. Yeah. I think it's interesting. So because you're come from a plastics background, your hesitation about a posterior release is mostly related to kind of the concept that the transversalis muscle is like your internal girdle, and that maintains the contour of the abdomen. Is that mostly your concern with the posterior release?
That's okay. I can go on of why the anterior release is better than the posterior release. Do you want the last? Do you want the talk? Are you ready for it?
Yeah, sure. The brief version.
The brief version. I can do a anterior release in 10 minutes.
Mm-hmm.
You find me a posterior release you can do in 10 minutes. It's not going to be done.
Mm-hmm.
Second, my release pairs beautifully with mesh suture. The whole idea of improving the lateral abdominal wall compliance and then just closing in the midline.
Mm-hmm.
But a posterior release requires a huge mesh. So from the plastics point of view, who's putting in the least amount of foreign material? You can still do a retrorectus with an anterior release,
Mm-hmm.
but I do a narrow well-fixed mesh, so 7.5 centimeters wide. But a posterior release, you're putting 20, 24 centimeter wide meshes.
Mm-hmm.
I have never in my life put in wider than a 12. Well, for the deep flap, I do a few TARs, but literally once a year I put in a 20 centimeter wide mesh, and that's about it. So conceptually, I'm going to have better tissue vascularity, less surface area that I'm opening up.
Mm-hmm.
So less complications, and the complications when they happen are more manageable.
Mm-hmm.
So anterior release, I think, looks better. Anterior release is faster. Anterior release, you can potentially use just a suture for closure.
Mm-hmm.
None of those things apply for the posterior release. But the posterior release, you can do as a robot.
Yeah.
And a posterior release, you can go home in a day. And my patients are in pain for 4 or 5 days.
Yeah, we're probably,
no question.
Yeah, we're probably for our posterior releases, majority of ours now are outpatient, and so those folks are going home from PACU. Yeah. So there's, yeah, and
I've never seen.
Yeah, we do it at a pretty high rate now, and I think that it's we've been successful at it, and you got to choose your patients, right? You know what I mean? Like this is not a one size fits all thing. You got to everybody's a little bit different. And you just got to actually practice clinical medicine, not just by an algorithm that you got to actually apply the right algorithm to the right patient. But I do think
when I say never, I'm saying my patients would never go home.
Yeah.
Yeah. That's what I'm saying. Yeah.
Oh, for sure. Yeah. No, I think, obviously I think that there's definitely, it's nice to have, it's very, very nice when you're doing hernia surgery because every patient is different and every patient has benefits from different types of repairs. And so having multiple options in your tool belt, I think has a lot of benefit for the patient. There's no, I tell patients all the time, there's no perfect hernia repair. And when we find it, it's going to be somebody's going to win a Nobel Prize. But everything has its benefits and risks. But if you're able to apply the right risk to the right patient and the right benefit to the right patient, you get really good outcomes. I think it's really neat what you do because it's not necessarily the most common thing that we talk about on this podcast or anything like that. So it's just it's an interesting perspective. But when you still do some just straightforward abdominoplasties without hernias? Do you still do some of that as part of your practice?
Oh, tons. I did one yesterday.
And do you mesh suture those? Do you mesh suture your implication?
Every single one.
Yeah.
So low transverse incision, lifting up the abdominal skin, just inserting the umbilical stalk. And then I'll run a mesh suture, usually the number one, from the xiphoid to the umbo, and then another suture umbo down to the symphysis. So usually 3 knots. I'll start at top, do a knot, bury it, run halfway down, start a knot at the umbo, run up to it, 1 knot in between, and the same thing below.
Yeah, we've done some scolas, with those robotic scolas, and so
with
far,
the mesh suture?
Yes.
Yeah, Flavio has done it. But again, the issue is the worse the rectus diastasis, then the worse the skin.
Sure. If it's too big, we don't. It's all about patient selection, and it's one of those. Now we're in a situation where you have those patients that come in and they may be a very fit female that has a very nice abdominal wall, but after their postpartum, they've just got just enough of a diastasis that it shows. They go to do a sit up and they're like, they've got a 6-pack and then the ridge, and you're going, well, you're not going to lose any more weight, and your core is obviously, you've done a great job with your core rehabilitation. It's not like it's the right time, and some of those folks, we worry about even in the suturing techniques to try to make sure that you don't get the the vertical ridge in the midline from a posterior approach and things like that. So those are, again, everything just goes back to patient selection and having a lot of different tools in your tool belt. In my case, it goes back. One of the things I'm a big believer in is it goes back to the surgeon themselves knowing their limitations, and I think that, and not being scared to be like, hey, I can theoretically do this, but I don't do very many of them, and my partner does these all the time. So you should see him. That's who I would want to see. And
well,
so those.
For instance,
those
I'm a hernia surgeon that doesn't do any inguinal hernias.
Right.
I mean, think about it. I don't do MIS. I can't offer something that is really kind of the standard, either laparoscopic or robotic. I can do a Schuldeis or a Schuldeis-like procedure with mesh suture. I'll do it in a woman if I'm doing an abdominoplasty and there's an umbilical hernia. And that's a chip shot with mesh suture. But talking about small hernias, I do lots of umbilical hernias where, the mesh suture has, in our hands so far, no recurrences at 592 days of follow-up. So, a local repair with the simplicity of a suture, but with the tissue integration and a decreasing of suture pull-through of a mesh. So that's actually pretty exciting. And the Danes are just literally starting now a mesh suture trial of European hernia guidelines, a preperitoneal mesh versus mesh suture. And so let's bring it on. There are 3 different RCTs in Europe that have basically accrued almost all their patients, and now we're just waiting for the data.
Yeah, we've been wanting in our practice. We've had numerous discussions about looking at these larger umbilical hernias that and just doing an open mesh suture repair. And I've used mesh suture for some umbilical hernias with the right counseling of the patient, for some folks that are probably going to need like future surgeries for other reasons. And so, I talk to them, I say, listen, could we do this and deal with the mesh and things like that? But this is the risk benefit of everything else. And I've had a couple of people that, were about it. We did it and everything seems to be going fine. You just got to make sure you bury the knot or they come back and they're like, what is this? But that's no different than if you don't bury the knot with a standard repair too. And it's just more permanent and more pronounced. But yeah, no, it's funny because kind of shifting gears a little bit out of the technical aspect of hernia surgery and more to a discussion about you. You were talking about you're in India and you've been at home hammering this out and you've been doing it really, it sounds like you were doing it mostly because of the benefit you saw in your patients. And you started to spread the gospel with the scientific evidence and everything like that. And that's good. But on a very personal level, and, it's really a 2-part question. One, you set out to be a hand surgeon. And did you have a situation where early in your career, when you were kind of going, hand surgery is not really happening, was that something that was difficult for you personally and professionally whenever you were kind of going, actually, it looks like I'm going to be this over here. I wasn't expecting it early in that phase. And then how does it hit you now that through all of the transitions of your career, some of which sound like they weren't planned, but just were a nice natural progression. How does it feel when you become known as like the mesh suture guy?
Well, I'm going to rewind. What I'm known for in the plastic surgery community is actually my amputee work. So I wasn't doing that much hardcore hand, but I did a lot of peripheral nerve. My teacher in my hand fellowship was really good in nerve. And so then we started doing these nerve procedures for amputees so they could move their bionic arms. That was pretty cool. That was also 2002. 2002 was a good year. And then did that for about 10 years. Then we recognized that people's pain was getting better. And that was from kind of an accidental finding. So I invented this procedure called targeted muscle reinnervation. I do it for chronic pain in the groins and the abdomen. So for 10, 15 years, I'm really just lecturing on this TMR. So I am known as a peripheral nerve surgeon.
Interesting.
And then the hernia thing was also just kind of happening simultaneously because chronic pain can wear you down in terms of, how many patients you can see.
Sure.
So the hernia was kind of my dependable part of my practice. And the pain patients Really love doing the work, but just the surgeries are just not as predictable.
Yes.
So when I look back, people have said, "What's your favorite surgery? Is it breast reconstruction? Is it hernias? Is it free flaps?" And to me, I know it's weird, but surgery is surgery. If it's good surgery, it's well done. So it has not. I do not focus on what type of procedure I'm doing. It's doing surgery, helping patients, teaching the residents about operating. That's the way I viewed it. So even though I've done really different things in my surgical career, none of them have really taken prominence over the other.
Interesting. Yeah.
It's a different, and I know people are like, "Don't you want to be a specialist?" Oh, I am kind of a specialist, but I'm a specialist in surgery.
Yeah.
And I'm applying it to different things that I'm doing. And so the idea of mesh suture being so ubiquitous to help surgeons, it's the gynecologists, the urologists, and the orthopedic surgeons, and the spine doctors. We use tons of mesh suture for spine closures.
Mm-hmm.
Right?
Yeah.
It's just putting tissue together. And then it goes back to suture pull-through is ubiquitous to a suture. Doesn't matter how you're applying it. I quiz the residents, what is the biggest problem in surgery? And then they'll say something like, yesterday I heard patient access. Well, that's a big problem.
Mm-hmm.
Or then they'll say infection, and then they'll say, and it's like, no, suture pull-through. Because if you never had suture pull-through, you'd get some vascular thromboses, okay, and you'd get some cancer recurrences, okay. But basically, all gut failures in the end are the things that the surgeon has put together falls apart.
Fair.
Right? And so that if you had a better suture that never let tissue fall apart, all surgical complications would come down.
Mm-hmm.
And I have been mostly applying this concept to hernias in the hernia world, but it's really ubiquitous.
Yeah. In a very, so you have been successful in multiple phases of your career. And I want to get to the mentality or just kind of your thought process, because I think that there are many people out there that may be early in their career or in mid-career, even like me, that are looking at what you've done and said, if I could accomplish just one of the things that you've accomplished, that would be personally, I would consider that a pretty big success. What is your definition of success? What's your is there like an innate drive within you that makes you keep pursuing these things, or do you feel like it's more just a curiosity, or is it focused on the patient more? I just want to get to the kind of the mentality that it is that drives you to get to those levels.
I'm not sure I can answer that. Let me just think about it a second. I mean, I drive for excellence, right? And I'm innately super curious. But I would say, and I'm pretty thoughtful. Things happen, and I think about it. Like, why did that happen? Like all the skin dying after the component release. But I would say the unifying factor is that I never do the same thing twice. I can't remember how I did it last time. So then I try something new, and I'm really a tinkerer. And a tinker refers to the guys who work with tin, and they tink, and they're just always kind of just fussing with things. And like when I walk to work, I always walk in a different direction or a different street. And I don't have a one way of doing things. And I think that the openness to doing things in different ways and then seeing the outcomes and moving it a little, and I think is the reason that I've been able to create targeted muscle reinnervation.
Right.
Or, like I saw that the way that we were handling nerves wasn't working. Mm-hmm. It's weird. Mesh suture is the first new suture in 40 years. There are all these surgeons in the world and all these big companies. It's weird that I was able to come up with the first new thing. I mean, it's only the third suture design ever. Mm-hmm. But I relate it to my being a tinkerer and and having an intuition of what's going to work and what's not at a very simplistic level. I mean, I'm looking at the cut on my finger and I'm like, that is not right.
Right. Yeah. So whenever being a tinkerer, always moving, always like progressing forward, identifying issues, having the curiosity to explore. During that process, there's obviously going to be times that you try things that don't work inherently, that you have a failure. Maybe you have a complication. And
like peristomal hernias.
Right. Yeah. So
I'm still working on that.
Yeah. So whenever you have that, I think that there's for instance, me, if I'm moving forward with something new in my practice, my partner and I were very different personalities and we complement each other very well. He's on the forefront. He's doing things that are, hey, if the study shows this, it's backed up by this study corroborated, I think we should try this. And I'm like, yeah, you should try this. and whenever you do a few, if the world doesn't fall apart, maybe I'll try it. And I think it goes back to the way that I think about complications. And realistically, I think this goes back to the psychology of a surgeon and how, despite us being in the same field, many people approach their life, their definition of success, and especially their definition of failure very differently. And I think that allows for people to do things. I would not be a very good inventor because I take my failures so personally. I don't take them as an opportunity to examine and improve. I do that. I'm not saying I don't learn from my failures, but to me, it hits me in a way that it is very core to my being. And whenever you're pursuing something and you try something that maybe doesn't work, how does that affect you personally? What's the mental thought process that you go through when you may see a failure of a new technique and you realize that maybe the technique failed and now you're kind of in this mode of fix it, or how does that affect you, I guess?
And I'm really not trying to talk big, but I've applied surgery principles in every case.
Right.
And I actually haven't had a lot of side directions that I've gone that ended up not working. I can think of one thing. I was using nerve allografts for chronic local pain and trying to reconstruct nerves. And I treated at least 20, 30 patients like that. And then 3-4 years later, I noticed they were still their pain had come back, and I abandoned that. But in my entire hernia world, I'm doing things really similar to how I did 20 years ago. Mm-hmm. So I've been fortunate to have good surgical intuition and reliance on principles. And this is all based on, being in the hospital 120 to 140 hours a week as a resident. Mm-hmm. I'm not saying I haven't had failures, but I have not had some big movement in my practice that I wish I hadn't done. So I started doing anterior component releases with just suture at a 23% recurrence rate. And then I started doing alloderm or biologic mesh reinforcement. I did literally only 16, 18 cases. And soon after, I realized that it was failing. And I had a 60% failure rate on those cases. But I only did 16 of them. Okay? Right. Then I went to intra-abdominal mesh, but a well-fixed narrow mesh trying to reduce the amount of failures. To reduce the amount of adhesions and bowel problems. And I had a 5% recurrence rate. I did maybe 100, 150 of those. Then I actually did pretty well. And then I started doing retrorectus. And the way I do a retrorectus, I've had 1 recurrence and 4 infections in my entire life. So, I've been moving pretty much in the right direction. Mm-hmm. Now, there's some people where I wish I hadn't done the retrorectus because it physically hurts. So now I'm in the mesh suture world. And so, but I'm still doing retrorectuses. But what I'm trying to say is I haven't, other than that nerve allograft thing, it's everything I've done is pretty, I'm not trying to talk big, but it's been working. Yeah. So I haven't had those big surgical failures where I have to look back and say, oh, why did I do that? on a global level. Sure, a certain patient might, gotten a DVT or PE, or, there are always those types of complications, or an SSI. But patients overall, I don't have any big regrets of some direction I've made in my practice that I had to retreat from.
So you'd say that really your success, so in that regard, you've been able to push the boundaries, but even in pushing the boundaries, you've been successfully doing so and been able to build off of that success. And what you're saying, if I'm understanding correctly, is more, it's built off of the fact that despite pushing boundaries, you're basing it on stable principles so that even when you're pushing the boundary, you feel confident and you feel comfortable understanding that the basis of the innovation is sound. And so if you have a failure, it's not that you were, thinking so far out the box that you made an assumption that failed. It was more a natural progression of a principle that you feel strongly about, which was just the core surgical principles.
Right. You said it better than me. And using a strip of mesh to approximate tissue, that was the one big thing not based on a human outcome, but based on rats.
Mm-hmm.
And I rapidly, watching that, was not seeing chronic draining sinuses. I wasn't seeing bowel adhesions, and patients were actually doing better than all of the other things I could have been doing. I mean, luckily, I was comparing it to using a biologic mesh with a 40% SSI rate and a near 100% recurrence rate. So the thing I was comparing it to was so bad that mesh strips, in comparison, was really pretty good.
Right.
But I would say going to mesh strips in humans was that one leap of faith that I made, just based on intuition. But then I was doing it very carefully, and the right patient, or with the retrorectus mesh behind them, or a pediculectomy, and I was just using it for an umbilical hernia. So I was being careful, and I watched my results for a couple of years, and then I started doing it more because the results were good.
And so really you've been able to track your results very closely, it sounds like, for a long time across a broad spectrum of surgery. And do you think that because I think in the community, many times people are in a very pressure situation of, you got a certain population of patients you're trying to take care of, and you're like hammering through these cases, and maybe there's a production drive from within your organization and things. And so I think a lot of people don't necessarily have a good grasp of their recurrence rates in the average population. But it seems like that has been very central to your success, both with your innovation and also just your success of the patients you've taken care of, is knowing that and being very cautious with it.
Staying at the same institution, that's really helped. And then we have a resident research here. So I have a resident available potentially to look at cases and to do research. And they're smart, and they're in my program. And so then, all of this has been, the residents have reviewed the cases, residents have determined SSI, SSO, recurrence rates. They're doing it now for mesh suturing. So that's how I know that I was 23% for components with sutures, 60% for intra-abdominal biologic mesh, 5% for intra-abdominal proline mesh, 0 for a retrorectus mesh. And now we haven't done the long-term follow-ups for the mesh suture, but for a contaminated incisional hernia, 8 centimeters wide on average, we have a 92% 1-year hernia-free rate. So I can quote numbers to you of how people are doing.
Mm-hmm. Now, whenever because like you said, you've been known for multiple things throughout the different phases of your career. And kind of a lot of those phases were happening simultaneously. Sounds like it's like 2002 was a year worth toasting. Whatever, in the future, whenever you're looking back on your legacy and what you've contributed to the world of surgery, what do you hope you're known for?
How to treat a painful nerve. And that is pretty recognized within the plastic surgery community. I won the Association of American Plastic Surgeons Achievement Award just before COVID, 2019, for my nerve work.
Mm-hmm.
And then if and when mesh suture becomes a standard of care for intra-abdominal closures, then I know I've made it for the larger surgical community, and that'll be fantastic. And that will be hundreds of thousands of patients who will avoid needing a second surgery.
And I think that the implications on that patient is enormous. The implications on the broader community and the broader society of the long-term disability associated with multiple hernia operations or hernia operation in general, the prevention of that, I think that's like hard to even calculate. I don't think we even know what that would look like.
Right. I mean, we want to put hernia surgeons out of business.
We might have to cut this part from the episode.
No, I mean, prevention, Bill Hope, when he was AHS president, I mean, it is there, why do the Europeans focus on small bites? Everyone is thinking the same thing. How is the best way to close a laparotomy? But there was a recent report in hernia of a 10.3% fascial dehiscence rate for an acute care laparotomy closed with small bites, back to the operating room 10% of the time. I mean, that is just unacceptable.
Or not, or they don't go back. And you
they don't go back. No. This article, this is University of Frankfurt, and they went back 10% of the time, and that's yikes.
Yeah. Or you just leave the staples in a little bit longer and cross your fingers and say we'll fix it in 6 months.
Yeah, well,
I think I think that obviously you're not going to find a hernia surgeon out there with everything that they're going for. That with the way that at least the vast majority of hernia surgeons I've talked to, it's really patient focused. Trying to fix something, because I think that the idea of it just being a hernia that may fly for the surgeon, but for the patient experiencing it, it's usually anything but. And I think that it's really interesting, and obviously applaud your innovation. It sounds like you've had a really systematic, thoughtful approach to the way that you've been able to progress through your career and the things that you've been able to pursue. I think something you said that really did strike me is the longevity at your institution has really allowed you to kind of grow and progress through those different phases. And I think that's also something that's very unique.
Well, I was a Cubs fan, and Ernie Banks and all the Cubs, you stayed their whole career with the Cubs. And I used to read these history books on baseball players, and the ones who stayed in one place always impressed me more. So in the Department of Surgery, I am unfortunately the senior guy by years in the academic faculty. But then when I started, with mesh strips, and then the people around me started using mesh strips, the acute care surgeons were using mesh strips. And then when mesh suture came out, they're like, should I use it, Greg? And I'm like, hell yeah, for sure. So then they started using it. So then, we've been able to do registry studies, and we're up to over 2,000 patients at one institution, right? And so then my research team can look at the numbers and publish. And so all of those rely on being in one place at one time, one institution.
Well, it sounds like you've captured the way that you approach your life, the way you approach your career, and then the support from the institution. It's kind of like you've captured lightning in a bottle that hopefully other people are able to do as well, because it's paying off. So as we come towards the end of an episode, I always give everybody the opportunity to give their hernia hot take, and obviously that's a chance for you to give your impression of hernia surgery, your prediction for the future. I have a suspicion what it might be entail or might involve, but I would love for you to give us your hernia hot take if you have one.
My hernia hot take is focus on suture pull through, the tension required on closure. Debridement, I didn't talk about debridement and preparing what you're going to close to get rid of scar tissue, bringing it together with a minimum amount of total implant. And that's going to give you the best overall patient experience in terms of success of the procedure, lack or complication rate, and those complications will be of a lower magnitude by not opening up these huge tissue planes. So that's what I hope hernia surgery moves towards.
That's fantastic. I don't think there's anybody that's more qualified to make that hot take than you. So we appreciate your the lessons that you've learned through your career so far, and we look forward for what's to come.
Thank you, Lucas. It's been, I hope, it's weird. I've never done this before. I feel like I'm talking too much about myself. That's what
the
you
point.
want.
Absolutely.
Okay.
No, this is like I said, this is a podcast about the hernia surgeon, not hernia surgery necessarily. I think there's so many avenues out there now, thankfully, that we can have the discussions about the technical aspect of what we do. There's so many people that have very unique and brilliant ways that they approach different problems that we come up with. And really the part about it that I think that we're missing, and I hope that this is able to at least start the discussion and other people can build on it and hopefully do better than I am. But the fact that, how we approach life as a hernia surgeon, how you approach life when you're doing the things that you're doing, I find that fascinating because there are definitely aspects of your career that I'm not sure I would have had the courage to do just with my mental makeup and things that I think that listening to people that have accomplished a lot gives me something to try to emulate. So at the end of the day, this podcast is completely selfish. I am shamelessly stealing from every guest the wisdom that they have to offer, so I can try to steal it from myself. So I really do appreciate your willingness to come on and willingness to have the conversation. And again, just thank you.
My pleasure, Luke. Have a great day. And now I'm going to go do some grocery shopping.
All right. Well, this has been another episode of the Hernia Gods Podcast. Thank you so much for listening. And this is your mere mortal host signing off. Thanks.
Okay.